Uh, so today we plan to discuss prenatal diagnosis. Actually, prenatal diagnosis. So uh, antenatal diagnosis. Actually, we are going to discuss something about the prenatal diagnosis. Okay, so why we want to discuss this topic today? Because this topic is very important for the theory as well as the Viva students, because we know, right? Because what is the importance of doing this prenatal diagnosis? So some students texted me regarding some question regarding the Down syndrome screening, uh, and what to ask for the or Down syndrome screening in Viva, and what is alpha fetoprotein, and different questions from the students. So then I thought, rather than explaining each and every one separately, so I thought to do it as a class. So then everybody will have some idea about what is this prenatal diagnosis and what is the significance of doing this prenatal diagnosis. So first of all, before we discuss about the prenatal diagnosis, first you should know two, three terminologies, and then we will discuss. So then, of course, we need to know about uh, what are the prenatal diagnostic modalities available, and you should know what is screening and what is diagnostic test in prenatal diagnosis. Okay, right. So first we will discuss two words. One, congenital abnormality. Second one is chromosomal abnormality. Yeah, Janet, good evening. So congenital abnormality and chromosomal abnormality. So please try to understand, because this is the very difficult subject in obstetric, right? So if you try to read it in your textbooks or maybe guidelines, maybe in your review articles, you might not understand easily because it's very difficult subject, but I can make you to understand in a nice way, right? So if you under, because we are having so many questions in this prenatal diagnosis, and these prenatal diagnostic modalities are emerging all over the world. So we are doing so many screening tests, we are doing so many diagnostic tests, and a lot of things we are doing. So even though we are in Sri Lanka, we are not doing most of the things. Still, maybe in 5 years, when you become a consultant, when you become a senior house officer, you should know these things. Still, some students, when we are doing the private practice, when we are doing in a hospital setup, they are asking, doctor, do I have any risk of Down syndrome? How to detect it? Do I want to deliver this down baby? So then you should able to diagnose it, or you should able to identify this Down syndrome, and you should able to do some intervention for this Down syndrome. Do you understand? Right. Okay. So just tell me, what is congenital abnormality, what is chromosomal abnormality? Anyone? Because there might be very young students, small students, maybe third year, fourth year. So then you might not know. That's why I'm asking. Some students from Viva batch might know these things. Yes, Sanjeevan. What is chromosomal abnormality? What is congenital abnormality? What do you understand by chromosomal abnormality? What do you understand by congenital abnormality? Right? So the congenital abnormality, there are some structural defect since birth. During the intrauterine life, there are some structural defect due to several causes. Maybe due to chromosomal abnormality, maybe due to uh, infection, or maybe due to exposure of teratogenic drugs. So there are so many insults, especially during the first trimester of the period. So as we know, the first 12 weeks we call first trimester. So during this first trimester period, the fetal organs will develop. That is called organogenesis. So during the organogenesis, if the baby exposed to some kind of insult, okay, then what will happen? Baby will develop structural abnormality, maybe cardiac structural abnormality, maybe a neural abnormality, maybe limb abnormality, maybe gut abnormality, maybe kidney or Jeju abnormality, whatever the abnormality, right? So that is called congenital abnormality. Second thing, chromosomal abnormality. So then in obstetrics, you studied a lot regarding this chromosomal abnormality in pediatrics. Isn't it, Sanjeev? So there are so many chromosomal abnormal baby you are seeing in pediatric ward. So first of all, you need to know what is chromosomal abnormality. What is the significance of chromosomal abnormality? So before we know about this chromosomal abnormality, you should know how many chromosomes we are having. In a human body, how many chromosomes we are having? Yes? Yes? Anyone? How many chromosomes? Annual. Yeah, thank you. So 23 pairs or maybe 46. So 23 from mother, 23 from father. So altogether we are having 46 chromosome or 23 pair of chromosome we are having. Do you understand? So it's half from the maternal origin, half from the paternal origin. So during the gametogenesis, what you understand by gametogenesis? So as we know, right? So there are two type of cell division. One is mitosis and meiosis. So what is the difference between these two cell division? One, during the somatic cells division. So it means when I'm growing, my cell is divided into two. So similar cell will be produced. So if you take a cell from my nose that has 46 chromosome. So when the cell is dividing, that cell also will contain 46 chromosome. Then only our chromosomal genetic stability will maintain. Do you understand what I'm telling? To maintain the genetic stability, the total number of chromosome will be maintained. Right? But during the gametes formation, like ovum formation or maybe sperm formation, so during the gamete formation, you can't have 46 chromosome. Why is that? Because if the ovum has 46 chromosome and sperm has 46 chromosome, when these two join to form a baby, what will happen? 46 plus 46, it's going to be 92 chromosome. Is it normal? No, it's double. So you can't have 92 chromosome because to maintain your genetic stability, always you have to have 46 chromosome. Do you understand what I'm telling? So during the gametogenesis, the cell division is bit different than the other cell division. Other cell division, 46 chromosome will divide into 46 chromosome. That is mitosis. But during the gametogenesis, what is happening? These 46 chromosome will divide into half. Unpaired 23 chromosome. Right? So the father also will produce 23 unpaired chromosome. Those two unpaired chromosome will meet and join to 46 chromosome. So 23 here, 23 here. Then now the daughter is having 46. Now you can see the total number of chromosome is same as human being. Do you understand? Right? So this is how the genetic stability is maintaining in human body. Got it? This is how the genetic stability is maintaining in human body. Do you understand? Okay. Right. Now, okay. So uh, in gametogenesis, when the cells are dividing, right, there might be some errors during the cell division. So errors can happen in anything, right? So that is the normal thing. Am I right? Yeah. When you do something, you can do mistakes. That is normal. So even in mitosis, so meiosis, During the gametogenesis also, there might be some errors. When the cells are dividing into half, right, sometime those chromosomes might fail to separate. Fail to separate. So when they are failed to separate, what will happen? So that chromosome will have two, then father will have one, altogether going to be three. So what I'm trying to say is, I will show you a bit later. So we have 23 chromosomes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 12, like the 23. Now, the first chromosome has two pairs. Now, what is happening during the meiosis? One pair is separating. Now, I have only one chromosome. Then another pair will come from father, and now baby has formed. So, during the meiosis, this paired chromosome is divided into unpaired chromosome. Right? So, during this meiosis, sometime these paired chromosome fail to separate. If they fail to separate, what will happen? Now they are going to have two chromosomes, paired chromosome in the egg. My first chromosome is paired. With this paired one, my father's one chromosome also coming. Now, how many chromosomes I am having? 3. Because the first chromosome is not separate, so there are 2. And father's chromosome also came, so now altogether 3. Right? So if the father's chromosome also not paired, so then how many chromosomes now I am going to have? 4. This is called aneuploidy. Aneuploidy. Aneuploidy means there might be problem in separation, so then you can have more chromosome or you can have less chromosome. Why? When the cells are dividing, if it is not pairing, one chromosome will have extra chromosome, another one does not have. So there might be a defect in number of chromosome in the baby, right? So I will teach you with the picture. We'll go with the presentation, then you might have some idea about this presentation. Now, okay, you can see this, right? So aneuploidy is the presence of one or more extra chromosome, what we discussed now, or absence of one or more chromosome. You can see here in this first picture. Here you can see this is dividing into one. This is normal. But in this picture, it's not divided. Because of that, how many chromosomes we are having? Here, 3. This is called trisomy. So, trisomy, having 3 chromosomes can occur in any of your 23 chromosomes. Not all the chromosome, any of your chromosome. Like maybe in first chromosome you can have 3, rest of the things are normal. Second chromosome you can have 3, rest of the things are normal. Third chromosome you can have 3, rest of the things are normal. Do you understand what I'm telling? So any of these, specifically any of these chromosome might fail to separate. So trisomy can be found in any of these chromosomes. So during the meiosis, having this aneuploidy is high risk. Especially this aneuploidy risk is increasing with increased maternal age. Aneuploidy risk is increasing with increased maternal age. So when you get married in late age, then your chromosomal abnormality risk is very high. So when you marry in young age, chromosomal abnormality risk is less. Do you understand what I'm telling? The risk of chromosomal abnormality is less with less age. Risk of chromosomal abnormality is high when the age is going. Okay? So you can have trisomy in all the chromosome, as I told you. Maybe first chromosomal trisomy, second chromosome trisomy, third chromosome trisomy, fourth chromosome trisomy. Like that, any of these 23 chromosomes, you can have trisomy. But the problem is, most of these trisomies babies are not viable. most of the babies will die. That's why most of the first trimester miscarriage will occur within the 12 weeks. Most of the mothers might have miscarriage during the first trimester because there might be chromosomal abnormality. So you can counsel the patient if it is a miscarriage before 12 weeks, if the pregnancy loss, you can counsel the patient that may be due to chromosomal abnormality. That baby is not suitable to live. That's why baby went out. Do you understand what I'm telling? So you can have trisomies, these chromosomal abnormalities in any of these chromosomes. But most of the trisomies will die. They are not suitable to live. But there are few chromosomal defects. Few trisomies can survive maybe 20 years, 30 years, 40 years. Right? So the commonest trisomy which can survive for a long age. What is the trisomy which can survive for a long age?
Trisomy 21.
Trisomy 21. So what is the name of the trisomy?
Down syndrome.
So Down syndrome means, so actually you can have trisomies in any chromosome. Most of the babies will die, but trisomy 21 can survive for a long period. Maybe 20 years, 30 years, 40 years. So that's why we could see a lot of trisomy babies, trisomy 21 babies. Do you understand? Rest of the trisomies might die. Other than trisomy 21, other than this Down, some other trisomies also can survive for short period. What are those trisomies?
Edward syndrome and Patau syndrome.
Yes. So Patau syndrome or trisomy 13 and Edward syndrome or trisomy 18. So those trisomies also can survive for short period. Rest of the trisomies will die. Even though this trisomy 13, trisomy 18, or Down syndrome, trisomy 21, even though they are surviving, those babies will have lots of congenital abnormality, cognitive impairment. They are not like you. Their intelligence is very low. Their cognitive development is low. Do you understand? Even though they survive for a long period, they have a lot of problems. Do you understand? So those babies are not compatible for the healthy life. Now we have a question. So like Down syndrome, so there are some other congenital abnormalities like Turner syndrome, Klinefelter syndrome, right? So super female XXX syndrome, XYY syndrome. So there are lots and lots of chromosomal abnormality. So all kind of this chromosomal abnormality, even though babies are surviving, still we have a question: is this baby is suitable to be in the life? Because they might have a lot of complications, a lot of congenital abnormality. So now we have a question: are we going to deliver this abnormal baby, which is not suitable for the healthy life? What is your answer? Are we going to deliver this unhealthy baby to burden the mother and the community and the health system? Is it good for the health system? Is it good for the mother? Is it good for the community? So are we going to deliver this abnormal baby? What do you think? No.
In Sri Lanka, yes.
Yes. Actually, we are not supposed to deliver the abnormal baby. Right? So we just forget about the Sri Lanka, but if you talk about the other countries, maybe UK, yes, if you are sure this baby is chromosomal abnormal baby, this baby is congenital abnormal baby, you can terminate the pregnancy, because we are not going to give the hard time to the patient. hard time to the mother. Because somebody has to look after this baby. Once the mother dies, who is going to look after the baby? That is our question. So, if it is congenital or chromosomal abnormal baby, once you confirm that congenital abnormal baby, then you have to terminate the pregnancy. We are terminating before the baby grown. So as early as possible, you need to terminate the pregnancy. But unfortunately, in Sri Lanka, the termination of pregnancy due to congenital or chromosomal abnormality is legalized. Sorry, it's not legalized. So you are not supposed to terminate the pregnancy. That's why prenatal diagnosis is not that much popular in Sri Lanka. But now there are a lot of argument with SLCOG and the ministry to legalize the termination of pregnancy for chromosomal abnormalities. So maybe in 1 or 2 years it might be legalized. If it is legalized, then of course you should know, because we are going to do it in routine manner, right? Okay, now, so if you know this baby is chromosomal abnormal baby or congenital abnormal baby, then you can think about the termination. Now, what you want to know, whether this baby really chromosomal abnormal baby, whether this baby really congenital abnormal baby. So how do you know? Until baby delivered, can you assess the baby, whether baby is having congenital abnormality, whether baby is having chromosomal abnormality? Can you assess until baby delivered? No, we can't. So after the delivery only we got to know, yes, this baby is having some kind of abnormality. What I am going to do? So we have to wait until the baby delivered. But after the baby delivered, you can't kill the baby, and it's burden to the mother. Then only the this obstetric team start to invent some investigations or some test. When the baby is inside the abdominal cavity, whether I can identify the uterine chromosomal abnormality, whether can I identify the chromosomal abnormality. If you can confirm the chromosomal abnormality, if you can confirm the congenital abnormality, then you can think about the termination. Agree? Yeah, you can terminate the terminology of pregnancy. So now you have a question. How are you going to confirm it? That is the first question. So if you confirm, when are you going to confirm it? That is the second question. So what do you think? The confirmation should be done at 10 weeks or 20 weeks? Which one is good? Confirming the congenital abnormality at 20 weeks and 10 weeks. Which one is good?
Earlier the better, sir.
Right.
Why earlier is better?
The mother less complications. If we intervene in
The
before, right?
simple explanation is, if you confirm it bit early, termination will have less complication. Because baby is smaller, when you terminate, then termination of pregnancy is easy and with less complication. But if the baby is larger, when you insert the misoprostol, then uterine rupture risk is high, bleeding risk is high, the termination risk is high. That is one. Second, this mother is suffering with this abnormal baby for 20 weeks rather than 10 weeks. If you can do it a bit early, then it's good for the mother. Do you understand what I'm telling? So, as early as possible, you need to identify. Second one, yeah, of course, Sanjeevan, it's psychological affection to the mother. And second one, right, you need to confirm with some investigation, confirmation. So, how can you confirm it? So, if you want to do confirmation of the chromosomal abnormality, then you need to take the tissue sample from the baby. Because if you want to assess the chromosome of mine, then you have to take the blood or tissue from me. Agree? Then only you can assess the chromosome and you can say, yes, you are a boy because you are having XY. Isn't it? Isn't it lesson there? Right? So this is what you are confirming. But For the baby, if you want to conform it, obviously you have to take the biopsy from the baby, then you have to prick the mother's tummy, you have to prick the uterus, you have to prick the amniotic sac, then only you can prick the baby and take the sample. So you have to prick a lot. So then there are a lot of complications like infection, miscarriage, right? Fetal abnormality. There are so many complications. So when you prick, if the patient is normal, then you are unnecessarily exposing to a lot of complication to the baby. Because baby is normal, unnecessarily you prick the baby to conform it. But ultimately it's negative. So then if the baby miscarriage due to this procedure, it's unwanted. So that's why what we are doing is we are not doing this diagnostic test for each and every baby, because there might be unwanted complications. So then what are we doing now? We are doing some screening test, right? So we studied, we know what is screening test. The screening test, the test which is used to identify the high risk population among common population, right? So your advanced level is a screening test. They are screening the people who are having high IQ among the general population. So high IQ people are selected to medicine. That's why you all are doctors. Got it? So the low IQ people are not made doctors. There might be maybe some other work. I don't know. Do you understand? So these are screening tests. So what is screening test? Screening tests are, we are doing tests to identify the high risk population. Now you can avoid a lot of unwanted tests or invasive tests to the low risk mothers. Those mothers does not have chromosomal abnormality. You identify, you separate the high risk mother. Now you have a high risk mothers group. Among this high risk mothers group, what you can do, you can do the confirmatory test. Do you understand? Among these high risk mothers, you can do the confirmatory test. That is called diagnostic test. So now we have talk about two tests. One is diagnostic test, another one is screening test, right? So we are doing this screening test for each and every woman, with this screening test we are identifying the high risk population. Then among those high risk population we are doing diagnostic test. So the aim of diagnosis or aim of prenatal assessment is to identify the high risk population. Once you identify the high risk population, do the diagnostic test to diagnose the chromosomal abnormality. Once you diagnose the chromosomal abnormality, offer termination and you can reduce the burden to the mother. Do you understand? So this screening can be different type of screening. Maybe biochemical screening, maybe ultrasonic screening, maybe chromosomal assessment, whatever. So these are screening, different type of screening. Now today we are going to discuss what are those screening, how we are diagnosing prenatally all these chromosomal abnormal baby as early as possible to terminate those pregnancy. Do you understand? That is the topic we are going to discuss. It's a very difficult topic. So far, are you all clear? Do you have any question so far we discussed? Actually, I wanted to do these difficult topics today because I can't explain these things through SMS. It's very difficult, isn't it, Lasanda? When students are asking questions from Down syndrome and all, it's very difficult. So then now everybody can easily understand what is it. Any question up to now? Because during the theory session, I can't cover entire topic, right? So it is bit difficult, right? You know, right? So we have 23, 21 classes, but so it's fully packed. So there are a few topics we can't cover during the routine theory session. So then, so if you ask those topics, then I will do as a free session. So then we can cover those topics in a free session manner, right? Because now I know most of the students attended to my class, and some students go through the part 1 exam as well, right? So mostly we are having theory students today, right? But anyhow, even though you go through the part 1, you should know. So we studied more, we did a lot of questions in prenatal diagnosis during the paper session, isn't it, Kavinder? Yeah, because we are having at least one question in prenatal diagnosis in your exam paper. There will be one question. There is no question on that. So you should know about the prenatal diagnosis. Anyhow, there is a exam batch students who are waiting to do the exam in May, June period. So please, you have to concentrate this class. That is very important. So already I think I have done the restreaming also earlier. So the students who are waiting for the exam as well as the juniors. So as you all are requesting for another theory session, new session, next week I will start a hybrid session. So we will cover rest of the important topics with that. It's going to be like clinically oriented as what we discussed earlier, right? So then students who are coming to Malathi clinical visit, you might understand. So how important what we are, so actually what we are studying in the Zoom classes, how important when you come to the clinicals, you might understand, isn't it, Lasanda? You are the witness, right? So you all are coming, then you should know, right?
Yes, sir. Of course, sir. Of course,
So
sir.
then it's clinical oriented teaching. So superficial teaching and telling something to you, it's not working at all. That's why I'm very proud to say this way of teaching, I could reach to 90% pass rate. So it's unimaginable. I'm really very happy with that. So the thing is very simple, right? So because the problem is not with the students. My students, all the students are very good in knowledge. But only problem, you don't know which is important and how to understand. So I didn't do anything much to you. I just made you to understand. That's it. So once I made it to understand what is the outcome, it's 90% got through. So 30% pass rate in obs and gynae, it's not your problem. It's my problem. If I am not making you to understand, then you can't pass. If I can make you to understand, you can go to 90% from 30%. So anyhow, so the Viva students, I am giving the priority for your clinicals, but if you come to the clinicals, it's good for you, at least not only for the exam, at least you can have some idea while you are coming to the vote round with me. So while we are asking, then you know how to apply this basic theory with the clinicals, right? So we will, so please, the junior students, please wait for another 1 or 2 weeks. We will give the priority to the exam batch students. Once the exam batch students finish, right? So I will give the chance to the juniors before you leave, go back to your universities, maybe Russia, China, whoever, wherever you, before you leave. So at least come for 1 week and stay in the vote, hang around the vote. That is more than enough. At least you can have some idea. This is a good opportunity. You can. So I will get the permission from the director. You can give the director letter from get the permission from the director, and you can join to the clinical session. That is a good opportunity for you. I will let you to come and learn from me. Learn from not me, from the patient, isn't it? You can learn a lot from the patient. So next week we will start the theory, but meantime, while we are doing those theory session, so after finishing this Viva session clinicals, we will start the clinical session for the juniors as well. It's going to be free session. So I never charge a single rupee for clinicals in hospitals. I never. So that is for you, make you to understand what is happening, how the patients, how you are presenting. But you need to understand. So anyhow, when we are doing after this theory for the exam batch, we will do the topic wise revision as well as mixed paper revision. That time you will realize how important this doing this paper. So if you want, you just go and have a chat with your seniors, then you will understand, right? So now So here, what we discussed earlier, that is what, so the whole population, what we are doing the screening. So then we identify the low risk patient, then we identify the high risk patient. Once you identify the high risk patient, then you have to do the diagnostic test. So what are the aim of your screening test? Why we are doing the screening test? So the first aim of the screening test is to identify the high risk patient, because we are not going to do the invasive procedure for each and every individual. We are doing the screening test for each and every individual and identify the high risk patient. Then you can do the diagnostic test for those high risk patients. Second one, if you identify this aneuploidy or chromosomal abnormal baby bit early, you can terminate the pregnancy in early pregnancy. So then it's going to be a miscarriage. But if you let this baby to grow anyhow, this baby will grow. Maybe this baby might die near to term or maybe after the delivery. So what is the problem? If the baby died after the delivery or near to term, then it will be counted as perinatal mortality. Anyhow, this baby is not compatible with the life. This baby has to die. There is no question on that. But if the baby died, it's counted as perinatal mortality. So if it is a perinatal mortality, that is a marker of country's health. So in Sri Lanka, the maternal mortality rate, perinatal mortality rate, all are comparable with the developed world. So because our health system is fantastic, right? So that is a marker of health system. Now, because of this perinatal mortality, our health system is graded as low. Why? Because we don't have this prenatal diagnostic system. We are not terminating the pregnancy, and ultimately this baby will die maybe near to term or immediately after the delivery. So then our perinatal mortality level will be high. So if you do this screening test, if you terminate this pregnancy, your perinatal mortality risk is less. Do you understand? Perinatal mortality is, and in utero treatment, sometimes some abnormalities can be treatable. You do some treatment. The baby is inside. So if you identify maybe like some abnormality like hiatus hernia, then you can do surgery, right? So in utero surgery and counseling purpose. What is counseling purpose? So you are trying to tell to the mother, Amma, your baby is having this problem. You are going to deliver a problematic baby. So then baby mother can prepare herself. Or mother can decide, okay, I will terminate this pregnancy. So you can counsel the patient. So giving sudden shock to the mother, it's not good. So you can make her aware whether she's going to deliver an abnormal baby or not. Right? Inform the choice of parents regarding the pregnancy. So some chromosome abnormalities are recurring chromosome abnormality, right? So if it is a recurring chromosomal abnormality, then you can do the genetic counseling. You can tell to the patient, no point in trying, because if you both are trying for this baby, next baby also going to have this problem, so then this baby also going to die. Then they can try with donor IUI or egg donation, whatever. Do you understand? So you can do some counseling, or sometimes you can terminate the pregnancy. And you have time to prepare the mother physically for termination or maybe for the delivery. So those are the advantage of screening. So what are the types of screening? As it is ultrasound scan and genetic. So yeah, you can identify some abnormalities with the biochemical. So the commonest abnormalities we are diagnosing with the biochemical assessment, one is neural tube defect. I will explain you what is this neural tube defect. Second one is Down syndrome and some other aneuploidies like trisomy or patau, maybe trisomies 13 and 18, right? Okay, what is this neural tube? So to understand this neural tube defect, you need to recall your embryology. So the nervous system is developed from the ectoderm. Yeah, here that is the ectoderm. From the ectoderm, the nervous system is developed. So here, what will happen? The body is going to fold like this. When the body is folding, the fold will fold. See, when the body is folding, this ectodermal neural origin will be formed as a tube. So inside the tube, as we know, so centrally we are having here, you can see, centrally we are having a tube layer here, and that tube will continue as a brain. So the brain and spinal cord. The brain and spinal cord. This brain and spinal cord will be covered with the meninges, we know, right? Meninges. So this meninges will contain cerebrospinal fluid. This is your basic anatomy which you studied in anatomy as well as surgery, right? So we have brain, we have spinal cord that is formed from the neural tube. So your neural tube will be covered with the meninges, just containing the cerebrospinal fluid. So when these neural tubes are formed, they are fusing to form a tube structure. You can see here the tube-like structure, right? So during the fusion, sometime that fusion might not be complete, incomplete fusion. There might be incomplete fusion. So if it is an incomplete fusion or weak fusion, what will happen? Through this incomplete fusion and weak fusion, the brain matter might come out. Here, see, you can see the brain matter is out. So the brain matter or nervous system might come out through this defect. Or sometimes meninges might come out. Here you can see meninges might come out with the cerebrospinal fluid. So ultimately, it is a problem with the neuronal developmental problem. That is called neural tube defect. Okay, that is called neural tube defect. So there are so many neural tube defects. Sometimes the brain matter is not formed. How do you call that? If the brain matter not formed, how do you call that? The condition.
Anencephaly.
Yeah, that is the condition most of the doctors are having. That is called anencephaly. No brain matter at all. So this is called anencephaly. Right? So this is craniocasis, open spina bifida, right? So sometimes closed spina bifida. So anyhow, here you can see the brain matters are exposed to outside. So if the brain matters are exposed to outside, obviously they are high risk to develop meningitis. They are going to have this neuronal defect like muscle weakness, maturation problem, defecation problem, walking difficulties, their motor development deficiencies. So it's going to be a problem for a patient. Sometimes these neural tube defects, some neural tube defects are correctable. If it is a spina bifida, you can make an incision and correct it. But if it is an anencephaly, can you correct it? What do you think, Lasandar? Is it correctable? No.
Impossible, right?
It's not correctable. It's preventable. You can prevent it, but you can't correct it. How can you prevent?
5 milligram folic acid.
Yes, we have to give high dose of folic acid supplementation. We can prevent this spinal cord defect, but you can't correct it. Some spinal defects are correctable, some spinal defects are uncorrectable. So if it is an anencephaly baby, definitely can this baby survive? What do you think?
No, sir.
Yes, I'm seeing so many anencephaly babies. Yeah, right? So the anencephaly babies won't survive. So those babies might die maybe 1 or 2 days, or maybe within 1 week, this baby will die. So your question is, are you going to continue this pregnancy after knowing this baby is anencephaly? No, because anyhow after delivering this baby, baby is going to die. So then we have to terminate it rather than continuing this pregnancy and giving the hard time to the mother. So first of all, what you want to know whether this baby has abnormality or not. So that's why we are doing screening. If it is anencephaly baby, we have to offer termination. If it is spina bifida, we can do the corrective surgery. Then you can refer the baby to the neurologist, not neurologist, neurosurgeon, and neurosurgeon will do the corrective surgery. Do you understand? But to do this, whether you want to terminate, whether you want to continue, whether you want to get the opinion prior to the delivery, whether you want to do the cesarean section, because can you go for a vaginal delivery with spina bifida, open spina bifida? No, because these nerve cells are outside the body. When the baby is coming through the vagina, what will happen? This nervous tissue might get damaged. So then you may have to go for a cesarean section. So the mode of delivery itself is decided when you identify the abnormality. So you need to identify the abnormality. So how to identify? What is the commonest test we are doing to identify this neural tube defect is one ultrasound scan. With the ultrasound scan, you can identify whether baby is having anencephaly, whether baby is having spina bifida and all. So you can identify with ultrasound scan. That is one. Second, you can do a biochemical marker called, what is that?
Alpha fetoprotein.
Yes, maternal serum alpha fetoprotein. Right? Maternal serum alpha fetoprotein. What is this alpha fetoprotein? It's a protein which is secreted or synthesized by the fetal liver. Right? So when there is a defect here, this alpha fetoprotein will enter to the maternal circulation, right? So raised maternal serum alpha fetoprotein, you can identify, right? So the normal cutoff is 2.5 mmol, but if it is a closed spina bifida, if the spinal cord is closed but only defect is there, but it's closed, so then your alpha fetoprotein level will be less. But if it is an open spina bifida, the alpha fetoprotein level will goes up. So almost you can detect 79% of spinal cord defect, your neural tube defect with alpha fetoprotein. So sensitivity to diagnose or identify or detection rate of the alpha fetoprotein. So if the alpha fetoprotein is high, 79%, you can say 79% of the spinal defect patients will have high level of alpha fetoprotein. Yeah, what is the question? So what is the other condition having increased alpha fetoprotein? Yes, give me some time, I will explain that also. Okay, no worries. So 79% of detection rate with alpha fetoprotein. If it is an anencephaly, obviously it's 88%. So anencephaly will be identified with alpha fetoprotein by 88%. Do you understand? And also, as we discussed, we can identify with the ultrasound scan also. What is the sign will appear in ultrasound scan is lemon and banana sign. Lemon and banana sign. You can see the banana, that is obliterated cystina magna, and the banana, so the lemon. So this is the banana, that is your cerebellum. This is called lemon and banana sign. So at least you should know So for your MCQ purpose, what are the things you need to know? What is neural tube defect? What are the ways of screening for neural tube defect? One is ultrasound scan, second one is alpha fetoprotein. So in alpha fetoprotein, closed neural tube defect does not have elevated alpha fetoprotein. Open neural tube defect will have elevated alpha fetoprotein level. That is the thing you need to know. And in ultrasound scan, you can see spina bifida, so lemon and banana sign. So keep it in your mind. Closed neural tube defect does not have elevated alpha fetoprotein. Open neural tube defect has elevated alpha fetoprotein. This is common MCQ. Please, the theory students, please remember this. Right? Okay. So now, what is alpha fetoprotein and what is the significant? So here it's produced by fetal liver, as I told you. It's crossed the maternal serum, right? So see, from the amniotic fluid through the placenta to the maternal circulation. So it's throughout the most of the time. So throughout the pregnancy, you can see it's from 12 weeks to 32 weeks. So please, this chart you need to know for your MCQ purpose, right? So what are the conditions will have raised alpha fetoprotein? What are the conditions you will have lower alpha fetoprotein? This is an MCQ. Please remember, right? Neural tube defect, especially the open neural tube defect, abdominal wall defect like gastroschisis, omphalocele, blood extrophy, congenital nephrosis, multiple pregnancy, and spontaneous fetal loss. Those are the conditions will have elevated alpha fetoprotein. What are the conditions will have low alpha fetoprotein? Down syndrome, Edwards syndrome, type 1 diabetes, overestimated gestation, and maternal high maternal height and weight. Right? So those are the conditions. So maternal obesity will have high alpha fetoprotein. So those are the conditions will have, low alpha fetoprotein. So those are the conditions will have elevated alpha fetoprotein. Those are the conditions will have low alpha fetoprotein. Right? So somebody asked, so as a doctor, you should know not only the alpha fetoprotein, also other condition, not only neural tube defect, also other condition also will have elevated alpha fetoprotein, such as preeclampsia, preterm delivery, low birth weight, underestimated gestation, low maternal weight, Afro-Caribbeans, male fetus, right? And previous pregnancy with elevated alpha fetoprotein and smoking. Those are the condition can have elevated alpha fetoprotein, right? Now we have discussed about the neural tube defect. Now we are going to move to the Down syndrome. So very simple, we discussed earlier what is Down syndrome. So the Down syndrome is the most common chromosomal abnormality which we are seeing the patient as this patient is living for a long time, right? So this is the most common cause for the mental retardation as well. So actually this Down syndrome was diagnosed or described by a person called Downs in 1962, right? So even though 80% of Down syndromes are diagnosed in neonatal units, still 20% of Down syndrome we can miss it. Okay, because some Down babies might be normal in clinically. The one reason is they might have Down mosaics. Have you heard mosaics? What is mosaicism? Anyone, have you heard mosaicism?
Mixture of the normal and abnormal chromosomes.
Very good. So the mosaicism is mixture of normal chromosome and abnormal chromosome. Mosaicism is mixture of normal chromosome and abnormal chromosome. That is called mosaicism. Okay, that is called mosaicism. So if it is a mosaicism, so then baby might have normal clinical features. So we might miss. So actually the features of Down syndrome, I'm not going to explain, like flat nasal bridge, macroglosia and protruding tongue and things like that, because you studied in physiology. So our aim as an obstetrician, as obstetric students, you should know how to screen and how to diagnose the Down syndrome when the baby is inside the uterus. How are we going to diagnose it? How are we going to screen it? Okay, so that is our aim as an obstetric student. Okay, so how to carry on in hybrid or screening test? So now we are going to discuss this Down syndrome in a different manner. One is, so you can do the screening in first trimester. You can do the screening in second trimester. Right? So what we are doing is, we are doing some screening in first trimester. We are doing some screening in second trimester. Right? So when you do the screening in first trimester, if your screening, first trimester screening revealed as high risk, straight away we are going to do the diagnostic test with invasive procedure. Do you understand? Sometime baby or mother might have normal screening in first trimester. Then what we are going to do, we are going to continue the screening in second trimester as well. Okay. So if second trimester screening is high risk, then you can go for a diagnostic test in second trimester as well. Sometime patient might come to the hospital in 14 weeks in second trimester. Then you can't do the first trimester screening, then straight away you start second trimester screening. And if the second trimester screening is positive, you have to go for a diagnostic test. So in summary, keep it in your mind. We are doing some screening in first trimester. We are doing some screening in second trimester. You can assess the risk in first trimester. If it is high risk, go for the diagnostic test. If it is low risk, continue the second trimester screening. If second trimester screening is high risk, then you can go for a diagnostic test. So then what is this hybrid or integrated screening? What we are doing is, we are integrating the first trimester screening and second trimester screening. That is your integrated. Rather than seeing only first trimester, rather than seeing only second trimester, you can do the integration with first trimester and second trimester. That is called integrated screening or hybrid screening. So when you combine this first trimester and second trimester screening, obviously your detection rate will be high. Do you understand? When you increase the, or when you do the screening in first trimester and second trimester, when you hybrid, when you integrate, definitely your detection rate is going to be very high. Do you understand? Your detection rate is going to be very high. So here we are using different type of screening method. Different type of screening method. When you are doing this different type of screening method, each and every screening method has different level of detection rate. Can you see again, when is the hybrid screening done? Yeah, of course, no problem. So the hybrid screening is, we are doing some screening in first trimester, we are doing some screening in second trimester. Then what we are doing, we are integrating both. We are assessing with two screenings. Say for example, I will tell you in a easy word, right? Now I want to check. So Sanjeevan, is it okay if I use your name? Right. Now I want to check whether Sanjeevan is a good person or not. Right. So then what can I do is, during the theory class, I can do some screening test. I can talk to him. That is one. Second, I can talk to the Sanjeevan parents. That is second way of screening. Third one, I can talk to the ask from the Sanjeevan wife or girlfriend. That is third one. Fourth one, I can talk to Sanjeev and friends. This is the first way of screening. Then with this screening, each and every method will have different level of detection. So can you detect 100% by talking with Sanjeev and wife or girlfriend whether he is good or not? No. Can you detect 100% by talking with Sanjeev and directly? No. Can you detect 100% by asking from Sanjeev and father or mother? No. Because your detection rate is not 100%. But the detection might be so. Maybe if you talk to the girlfriend, then your detection rate might be 70%. If you talk to the Sanjeevan parents, detection rate might be 80%. If you talk with Sanjeevan for 5 minutes, your detection rate might be 30%. Because within that 5 minutes, you can't detect the people. Then detection rate is less. If you talk to the friends, maybe 90%. So each and every individual screening method will have different level of detection rate. Then what can I do? I can combine all these four. Then what will happen to my detection rate? If I combine parents, girlfriend, friends, and myself, then what will happen to the detection rate? When I am combining, it will be high. This is what I am doing in first trimester. So in first trimester, I am doing different level of screening method. Maybe nuchal translucency level, nuchal thickness level, assessment of nuchal thickness level. I will teach you what is it. Oh, I can assess PAPA-A, pregnancy specific plasma protein A. That is a marker we can use to assess the risk of Down syndrome. Oh, I can do alpha beta protein. Right? So there are some markers. So some markers you can do it in first trimester. Some markers you can do it in second trimester. Each and every markers has different level of detection rate. Do you understand? Then finally what I am doing, I am combining all the marker. Why I am combining all the marker? Maybe in first trimester and second trimester. What is the purpose of combining all these marker? To increase the detection rate. Do you understand? To increase the detection rate. So what is this hybrid or integrated screening is? So you are hybriding the first trimester and second trimester screening, and you combine both and you can increase the detection rate. That is called hybrid session. So hybrid screening. Then what is sequential or contingency screening? What is sequential and contingency? So in contingency, what I am doing is I'm just doing the first trimester screening and I'm continuously doing the second trimester screening and I'm combining with both. That is sequential or contingency. Almost like your hybrid session, hybrid screening. Right, now I'm going to teach you the individual sensitivity of identifying the nuchal translucency, right? So here you can see like if you do the nuchal translucency, what is nuchal translucency? So we are measuring the length of the skin thickness from the spine to skin back of the neck. That is called nuchal translucency. So usually in Down syndrome, the length of the skin will be thickness of the length will be high. Right? So increased NT is a marker of Down syndrome. But increased NT, it's not always due to Downs. That may be due to some other causes as well. But if you can see increased nuchal thickness, it is a marker of Downs. So then what I am doing is I'm combining this NT, combining this PAPA. When I am combining these two, my detection rate is going up to 90%. See, right? Here you can see first trimester screening. So you can see the individual detection rate. Maternal age, if it is 37 years, when the age is going up, the sensitivity of the test is less. So, right? So maternal age alone will detect only 30%. Beta HCG alone will detect only 35%. Papa, low Papa will detect only 40%. But when you combine these three, maternal age, free HCG, Papa, then your detection rate is 60%. Now you have some question, how to calculate this detection, how to combine this one. There are computerized programs. What you want to do is, you want to put the patient's age, you want to put the beta HCG level, you want to put the Papa A level, then the computer will say, what is the risk of Down syndrome? Do you understand? You don't need to calculate. Computer will calculate and tell you what is the risk of Down syndrome. So here you can see, when you are combining, here when you are seeing the individual one, only age it's 30%, only HCG 35, but when you combine the age and the beta HCG and Papa, it's going up to 60%. The detection rate is going up. When you combine the maternal age and nuchal translucency, your detection rate is almost 75%. Right? When you combine everything, maternal age, HCG, Papa, and nuchal translucency, your detection rate is almost 90%. So this is called combined. What you understand by combined test? The combined test is ultrasound feature, maternal age, and serum marker. Muted. Okay. Right? So maternal age, serum markers, and nuchal translucency. When you combine all these three, your detection rate is going up to 90%. This is called combined test. So now we know, when you do the screening, rather than doing the individual screening method, when you combine the fact, the detection rate is going up. So at least you need to know what are the screening method we can do it in the first trimester and which one is better, right? So here during the second trimester we are doing different screening method because these are specific to first trimester. Then we are doing some different screening method for the second trimester. In second trimester we are doing triple test and quadruple test. Triple test, what you understand by triple test? In triple test, we are assessing alpha fetoprotein, HCG, and estradiol. That is triple test. Even though it's a bit difficult, you will get more questions. So, theory students, please remember these things. Triple test has 3: alpha fetoprotein, HCG, and estradiol. And quadruple test, we are having 4. Right? Alpha fetoprotein, HCG, estradiol, and inhibin. There are 4. Alpha fetoprotein, HCG, estradiol, and inhibin. E3, E2, right? Inhibin. So in Down syndrome, among these 4, alpha fetoprotein, HCG, estrogen, and inhibin, among these 4, which one is high, which one is low? This is an MCQ point. In Down syndrome, you can simply remember, in Down syndrome, high is high, HI is high, HI mean HCG and inhibin will be high. Estrogen and alpha fetoprotein will be low. HI, HCG, inhibin high, high, right? HI is high. Estrogen and alpha fetoprotein will be low. So this is MCQ points. Please remember this one. So we are doing some first trimester screening. We are doing some second trimester screening. Then what are we doing? We are just doing hybrid screening. That is, you are combining your first trimester and second trimester. Then your detection rate will goes up. Right? Even sometime patient might come in later. Maybe patient not coming in first trimester, then your first trimester screening is not possible. Patient didn't come up to 14 weeks, then your second trimester screening also out. So then patient came a bit later, maybe 18 weeks, 20 weeks. Then still you can do some screening with the ultrasound scan. Right? That is called ultrasound soft markers. Ultrasound soft markers, which will help you to do the amniocentesis, which will help you to assess whether you want to do the amniocentesis. There are ultrasound soft markers will used as screening. If it is atrioventricular septal defect, AVSD. So during the anomaly scan, if you can see atrioventricular septal defect, that is 50% detection rate of Down syndrome. Oh, nuchal fold more than 6 millimeter, 40%. Renal pelvic dilatation more than 4 millimeter, 25%. Double bowel appearance, 20%. Echogenic bowel, 10%. So there are soft markers in ultrasound scan will help you to detect the Down syndrome. Do you understand? Will help you to detect the Down syndrome. So you can see the features. Actually, I have sent the presentation. You can see these ultrasonic features of this Down syndrome, right? Now those photos. So now this is a new screening method which has very high sensitivity and detection rate. Have you heard this cell-free DNA screening? Have you heard this cell-free DNA screening? Yes? Yeah.
Yes, sir.
What is this cell-free DNA? Okay, I will tell you. When our cells are degrading, right, due to the aging or maybe due to some other reason, when the cells are getting damaged, right, the DNA which is inside the cells will be released into the bloodstream. Otherwise, usually DNA will be inside the chromosome. Chromosome will be inside the nucleus, not in the bloodstream. Isn't it? Not in the free form. Because DNA will be inside the chromosome, inside the nucleus, not in a free form. Agree? So when the cells are getting damaged, this free DNA will be in the blood. So if you check the free DNA in my blood, will you get free DNA? Yes. Because every time a lot of cells are degrading and free DNA will be released into the bloodstream. Agree? There will be a lot of free DNA in the blood. Same thing will happen to the mother. Mother will have free DNA of her body. At the same time, the fetal tissue also will be degraded. So fetal DNA will be in the bloodstream. These cell-free DNA will cross the placenta and also it will enter into the maternal circulation. Do you understand? Also, it will enter into the maternal circulation. Now, in the mother's blood, will have mother's cell-free DNA and fetal cell-free DNA. Agreed? The mother also will have her own free DNA, and also the fetal DNA also now in the maternal blood. So if you take the maternal serum will have cell-free DNA of mother as well as baby. Around 90% of cell-free DNA belongs to mother. 10% of cell-free DNA belongs to the baby. Now what we are doing is, we are just taking the maternal serum and do centrifugation. And once you do the centrifugation, you can take the cell-free DNA. From the cell-free DNA, you can remove the 90% of maternal DNA. Now you are having the fetal DNA. If you have fetal DNA, from the DNA, you can detect so many genetic problems of baby. Without penetrating the baby, you took the fetal DNA from the maternal blood. Do you understand what I'm telling you? Otherwise, if you want to take the fetal DNA, then you have to prick the uterus, you have to prick the amniotic fluid, you have to prick the baby, then only you can take the fetal DNA. Now, without pricking the mother, without pricking the baby, I took some DNA from the baby, from the maternal circulation. That is called cell-free fetal DNA. Do you understand? So from this 10% of cell-free DNA, you can detect so many things. One, you can detect Down syndrome. Second, you can detect the fetal sex. Third, you can detect the fetal blood group. Fourth, you can detect so many fetal gene disorders like thalassemia, sickle cell anemia, any kind of genetic disorders. So this is good advantage. We can detect so many fetal genetic problems while the baby is inside, without pricking the baby. That is called cell-free DNA. So by 6-7 weeks, you can identify what is the sex of the baby by maternal cell-free DNA. By 16 weeks, you can detect the fetal blood group by maternal cell-free DNA. If it is Rh negative mother, then you can detect the fetal blood group. If baby also Rh negative, then you don't need to give the rogam. Do you understand? So you can detect the fetal blood group by cell-free DNA. Likewise, you can detect the Down syndrome as well. But there is a small problem. Due to some reason, right? Due to some reason, the detection rate of cell-free DNA for the Down syndrome is 99%, not 100%. If you want to diagnose a disease, that should be 100%. Agree? That should be 100%. But the cell-free DNA for Down syndrome is not 100%, it's 99%. So as it is 99%, it's not a diagnostic test. Still, it's a screening test. Right? So you can do the cell-free DNA. If cell-free DNA is positive, 99% you can say the baby is down. Only 1% baby might be normal. So is it available in Sri Lanka? What is the answer? Sanjeevan. Yes, it's available in Sri Lanka. Yeah, it's available in Sri Lanka. In private sector, not in government sector. Cell-free DNA is available in Sri Lanka. So you can do. So if you are a person who can afford for the cell-free DNA, you can do the cell-free DNA for even to identify the sex, even to identify the blood group, even to identify some genetic abnormality, even to identify Down syndrome. Yes, you can do it. Okay, so as a theory student, always you need to know cell-free DNA definitely not a diagnostic test, it's a screening test. Right? Definitely not a diagnostic test, is a screening test. Please remember it. Okay? Right. So cell-free DNA might be wrong due to some reason. One, that's okay. Just tell me why it's not 100% true, because there might be placental mosaicism. What is placental mosaicism? So this cell-free DNA might come from the placenta also. So if the placenta might have abnormal chromosome, not the baby, still you will get down chromosomal DNA, but it's not belongs to the baby, so baby might be normal. That is one of the reasons for the cell-free DNA wrong. Second, vanished twin. So there might be two twin earlier, one twin might died earlier, second twin is alive. So this cell-free DNA belongs to the death baby. So that's why you are getting this Down syndrome, but actually the live baby is normal. Do you understand? So that is the reason the cell-free DNA is 99% detection rate, not the diagnostic test. It's a screening test. Okay. So there are advantage and disadvantage of cell-free DNA. Now we will move to diagnostic test. So far we have discussed about the screening test, right? So the screening test can be, we are doing in first trimester, second trimester, sometimes we are hybrid, we are integrating first trimester, second trimester screening, right? So the first trimester, each and every screening test has different level of detection rate, but when you combine this detection test, then your detection rate will goes up. Do you understand? So the higher sensitive test to screen the Down syndrome is cell-free DNA, which is 99%, but we are not frequently doing this cell-free DNA test because it's very, very expensive. That's why we don't do freely. But if you have money, yes, like, yes. Right? Now, those mothers who are having positive screening test, those mothers who are having positive screening test, we are going to do the diagnostic test. What are the diagnostic tests? Yes, what are the diagnostic tests? Anyone? Any idea?
Amniocentesis and chondrocentesis.
Right. So you can take the fetal tissues from placenta. That is one. Because placenta belongs to the baby. Second, you can take the fetal cells from the amniotic fluid. Third one, you can take the fetal cells from the fetal blood. So where you can collect the fetal blood is from the umbilical cord. So there are three areas you can collect the fetal cells. One is placenta, second one is amniotic fluid, third one is fetal blood from the umbilical cord. So when you take the tissue from the placenta, that is called chorionic villus sampling. When you take the fetal tissue from the amniotic fluid, which is called amniocentesis. When you take the fetal blood from the umbilical cord, that is called chondrocentesis. So these are the three procedures: chorionic villus sampling from the placenta, amniocentesis from the amniotic fluid, chondrocentesis collecting the blood from the umbilical cord. Do you understand? Great. Right? These are the three things. Okay? Right. Now, why we are having these three methods? Is there any difference from these three methods? Yeah, of course, there are differences. So what is the difference? One, so when you can perform these procedures, if it is a chorionic villus sampling, you can do it bit early. By 10 weeks, you can identify the placenta and you can take the sample from the placenta. But it's difficult to take the amniotic fluid in early POA because the amniotic fluid, the water around the baby, it's less. So then you can't easily take the amniotic fluid. Even if you take the fluid in early POA, complications are high. So if you want to do the diagnostic test in early POA, then chorionic villus sampling will be best option, because that can be done in early POA. Okay. But with increasing POA, what will happen, right? With increasing POA, what will happen? Your amniotic volume will increase. When the amniotic volume increase, what will happen? You can easily collect the amniotic fluid. So amniocentesis can be done around 16 weeks to 17 weeks. When you do the amniocentesis, the complications are less when compared to choriocentesis. Right? But if you want to collect the fetal blood, the baby has to grow, umbilical cord should develop, then only you can collect the blood from choriocentesis cord. So choriocentesis can be done after 20 weeks, around 18 to 20 weeks, maybe after 20 weeks. So choriocentesis can't be done in early POA. Do you understand? So there are difference in collecting sample with these three methods. You can do the amniocentesis, you can do chorionic villus sampling, you can do choriocentesis, but will differ from your period of gestation and your complication level as well. Okay. Now we are going to discuss different methods. So chorionic villus sampling, actually this process is referred to the sampling of placental tissue or placental biopsy. You can start to take this biopsy from 10 weeks onward. Right? So the background risk of miscarriage is more than 1%. More than 1%. So there are two ways of taking the biopsy. One, transabdominal chorionic villus sampling. Second one is transcervical chorionic villus sampling. So if the placenta is the anterior placenta, then you can prick the abdominal cavity and you can take the biopsy easily. If the placenta is posterior, then rather than pricking the anterior wall and going to the posterior wall, through the cervix, you can easily reach to the posterior placenta and you can take the placenta tissue. So if it is a posterior lower lying placenta, then transcervical route might be good option. These are the two ways of taking the placental biopsy. So there are advantage and disadvantage, right? So the advantage is your tissue, you can take large amount of tissue, and the disadvantage is the confirmed placental mosaicism is 2% and miscarriage risk is 1%. That is the disadvantage. Then second one is amniocentesis. You can see here you are pricking the abdominal wall with the ultrasound scan guided. Here you can see the needle which is draining the amniotic fluid. So usually we are taking 15 to 20 milliliter of amniotic fluid with 22 gauge needle. So which can be done maybe 15, 16 weeks, right? Once the fluid comes. You can do the amniocentesis in early POA. That is called early amniocentesis, but problem is it has a lot of complication, like miscarriage rate is around 7%, and also which can cause talipes and Potter's syndrome. Those are the complications of early amniocentesis, right? So there are advantage of amniocentesis. Here you can assess the blood group of the fetus, right? And you can do some infection screening like cytomegalovirus, toxoplasmosis, and lung maturity assessment, right? And disadvantage, so it takes some time for your culture. right? So that is a disadvantage. And finally, fetal blood sampling, right? So here, as we discussed earlier, you can see this is the umbilical cord. We are taking the blood from the umbilical cord. So usually it start after around 20 weeks, right? So 18, so 16 to 80 weeks, 18 weeks. So it's around 20 weeks only. You can take the sample, right? So overall procedure related fetal loss is around 1 to 2 percentage, right? And the advantage, rapid and quick sampling, right? The risk is disadvantage is risk of miscarriage is 1 to 2 percentage. Risk of miscarriage is 1 to 2 percentage, right? And the fetoscopy, this is the newer method we are doing nowadays. We are putting the scope inside, right? And through the scope you can insert the camera. While looking the camera in television here, TV, with the inspection you can go and identify the placenta and take the sample. You can identify the umbilical cord and take the sample. And it's good to do the fetoscopy, because if you want to do the sample for twin pregnancy, here you can see one baby is large and other baby is smaller, so then you can take the sample from appropriate baby, right? So nowadays these fetal medicine specialists are using this fetoscopy. Right. So far we have discussed about the prenatal diagnosis. So in summary, so the prenatal diagnosis is diagnose the aneuploidy or congenital abnormality before the delivery to minimize the perinatal death and the maternal depression. And we are offering the termination of pregnancy once you diagnose the disease, right? So then of course we should know what are the methods. So there are screening and diagnostic. That screening we can do it in first trimester and second trimester, and we can do the diagnostic test mothers who are having high risk of screening test. So each and every individual screening test has less detection rate, and when you combine this screening test, your detection rate will goes up. Okay, so when the mother is high risk, then we can go to the diagnostic test. The diagnostic test are chorionic blood sampling, codosynthesis, and amniocentesis. Right? Any question? It's a very difficult topic, I know, but I don't know how many of you understood. But if you don't understand, no problem. We will do it again during the paper class. But when you do the question only, you will understand how important this is. Any question? Won't it cause miscarriage? Which one? Fetoscope. Fetoscope. Actually, everyone will have risk of miscarriage, but anyhow we have to do it. We don't have any other option. That's why we are doing for the high risk patient, not for the older patient. Yeah, any question? So I'm really sorry for those emergency students. I was I stuck in some commitment. So we will discuss the theory, that emergency part tomorrow, and we'll start the theory session next week. So when will you start the theory class from new students? Next week, next Saturday. Next Saturday, I'm starting the new theories batch. Thank you, Lasandha. I just want to do these difficult topics for you, make you to understand. That's why. Because if you start to read, you can't understand. That's the thing. So is there any specific period of gestation to do the diagnostic test? If screening test positive? No. If screening test positive, immediately you have to offer the diagnostic test. So if diagnostic is confirmed, then you can offer the termination of pregnancy as early as possible. That's why we are doing the diagnostic test. So no need to wait until the period of gestation increase. twin, should we do diagnostic test straight away or screening test for the down? No. We can do this diagnostic screening test initially, but the cutoff values are different from the singleton pregnancy. The screening tests are applicable for the twin as well. Theory class will be a hybrid session. So there will be some part will be restream. Most of the part, some part I will do as a live session. When we can reach the emergency restream. So I'm finishing the stage 1. Now maybe within 2 weeks you can watch the emergency restream. Probably the theory batch students will get the 24-hour restream. I'm working on that. We'll see. Which diagnostic test is best in 3 tests? It's like that. Amniocentesis will be best because with the less complication, it will be good. Yeah, I will send Nasik.